अभी कितना डेलीगेट्स है?
नहीं, अभी नहीं पता चलेगा, एंड में पता चलेगा।
अच्छा, एंड में।
Good evening, everyone. We welcome you all to OrthoTV online webinar series. Today we have a senior arthroplasty surgeon. He is from Faridabad, NCR. So his name is Dr. Sujoy Bhattacharjee. He is very well trained internationally from USA and UK. He is director and head of department of Center for Excellent Joint Replacement Center, Sarvodaya Hospital. He is going to talk to us on tips and tricks in CR knee, which will be a case-based discussion. This webinar is brought to us by Biorad Medicis, the makers of Genius CR knee. So over to Dr. Sujoy Bhattacharjee.
Thank you very much. It is my gratitude, and I want to thank the Biorad and OrthoTV also to give me a platform to speak on this CR knees, which is very close to my heart. Because CR knee, I think is there is in all conferences there is a fight whether CR knee or PS, because I think the increased amount of the CR surgeons are there, and I hope that there is a definite reasons why there has to be increase in the CR surgeons, and it is my moral duty, and I feel that there is a huge scopes for the CR knees for doing a TKA in India, because there are different regions are there. Most common regions, I think one of them is we have a very small knees. Indian females are short stature, very small knees. If you take the PS box cut, after the box cut, the hardly few amount of bone left in both the condyles. And if such patients need the revision, then there is a big issues. I think in such cases, considering all other facts of this fight, the PS and CR surgeons, this is a very small, I think, and the first and foremost reasons why I have been shifted 100% to the CR knees for the last more than 5 years. And I am here to tell you that basically there is no fight. I'm not going to say the CR knee why better than the PS knees. Because here in India, basically all of us, even me also, I started my practice orthoplasty with the PS knees. But gradually I start converting myself in CR, and for the last 5 years, gradually I converted the CR knees completely. For the last years, I haven't converted single knees to a PS knees. For the last years, 100% I'm doing the CR. So why I'm here? I am here to present some things because previously there was some barrier. People say, when I first saw CR knees, one of the surgeons in India, he told there is a limitation of doing a CR knees. In all cases, you cannot do CR because you can do only some selected cases. But I've been visited different parts of the world and I have seen it. It is possible, and I started practicing. And I'll show you a couple of very complex primary cases where you feel that it is impossible to come across with the CR, but I have done CR knees. And that is my commitment, and that is my issues. I'm here with you to show you few difficult, complex primary cases where I operated with this primary CR knees with the flat pulleys. And if you see why there is an advantage of the preserving the PCL, it is give the normal rollback, preserve the proprioceptions. But there is a fights. I don't want to. These are the accepted. You can say these are accepted advantage of keeping or saving the PCLs. But some people say that this proprioception, it has got no use, and there are hardly any proprioceptions keeping the PCL. But it is there. Rollback up. There's a out of need of the cutting the bone box. That is the most important and foremost reasons why I converted me to a CR surgeries, because in the Indian knees are very small knees, bone cut sometimes is difficult. Making the recovery fast with full flexions, because CR knee, I think, because we first foremost important fact is that we balance the knees in flexion first, then you go for the extensions. And in all my CR knees, there's hardly any issues of flexion and extension. They have the same equal amount of flexions, what we expect in that patient if you're using some other type of implants. Reduces the risk of complication, of course, while using the shear knees, because you will be very cautious to cut the tibia cut, because you have to save the PCL, so your saw should go is a divergent way. It is not a convergent way. If it is a divergent, then you are away from the mid part, means there is a less chance of vascular complication, if at all it is there in the PS knees. The less operative trauma, of course, you are preserving a most important structures. Definitely, there will be less amount of operative trauma. Inherent stability. I am absolutely in favor of this point, inherent stability, because I feel that the PCL is the most important factors which gives a stable balance in both the compartments of the knees. The less load between the bones and cement, that gives the increased life of the implants, and is good for the revision surgeries. I'll show you cases where you can come across revision of the shear knees. You can revise with the implant where we need the minimum amount of poly. We need not to go for this sleeve or cone. Some things are all the revision things it doesn't require, because most important part of the bone is the middle part of the bone, the condyles. It is saved. So it means that you will be using less amount of revision implant. In that case, you will be reduce the cost of surgeries, and you reduce the cost of, because you are not using the huge poly or not using the cone or sleeve. You are more biological, so it gives the better results. And even without cement, I think the most common. In India, there are, I think, one or two cases the companies are marketing, not much, but I think there is a scope, because right now you are getting the younger patients for coming for this TKA. In such cases, we can, of course, we can try with this non-cemented femoral part, not in the tibia, of course. Tibia is difficult in India, but non-cemented femoral part, that is good if you're using the shear implant. I just simplify the technique of this shear knees. I feel that this is my experience on what I'm sharing for the last about more than a decade. And this is my experience sharing the shear knees. Always complete the femur cut fast. I think sometimes it is when there is a flexion deformity is more than 20-25 degrees, it is in dilemma whether I have to cut more and less. You cut less if you want to cut more. Distal femur cut, you can cut in the lateral one also. We cut starts with this. If the flexion deformity is more, you can cut 2 mm more. Don't go beyond that. If you need, you can come again to the femur part. You can cut femur. You just starts with you complete all femur cut fast. That will be very easy for doing the shear knees, because we always balance the shear knees in flexion fast. There is a balance the knee in the flexion, then we balance the knees in extensions. But in the PS knees, we always balance the knees in extension fast. Tibia cut is either with a natural cut or you give the 5 to 7 degree slope. Because in the PS knees is always the 0 degree slope or less than 5 degree, but in the shear knees, the natural slope is always 5 to 7 degree. But if there's a recurvatum is there, in that case, you have to reduce. I'll show you cases where the recurvatum, I reduce the slope, and sometimes the slope is 0 degree in the shear knee also. Decompress the PCL. If you are 20 minutes surgeons, then it is very difficult to come across the shear knee, because sometimes shear knee, it takes more time, because you have to be very cautious and meticulous to decompress the PCL, because many times the osteoids are there just behind the PCL, which is difficult to balance the knees. So you have to decompress the PCL before putting the child implant inside, because if you are not decompressing the PCL, you try to decompress, they try to put the child implant there, it can be avulsed, it can come out the PCL. In that case, you have to convert to PS knees. So decompression of the PCL is the most important thing. So it takes some time. It's some the precisions. It takes time. You cannot do it in 20 minutes surgery, the whole TK. In sometimes it takes 10 minutes or more than that to decompress the PCL, because you cannot sacrifice the PCL, because you have to using the flat poly. You have to preserve end amount and the total amount of the PCL. Then only you can come across with the shear knees with the flat polys. Then PCL balancing is one of the most important factors for doing the shear knees. And if there is first things, if the flexion space is tight, you can increase the slope. And even if you increase the slope, you cannot get into this trial, then you can little bit of additional posterior condylar cut, or maybe release the anterolateral band of the PCL is hardly required. But in that case, if you are releasing the anterolateral band of PCL, in that case, better to go for this ultra-convenient poly or UC poly or whatsoever poly is there. But the normal flat poly, it is sometimes difficult because there may be sliding from the anterior side because you release the PCL. This anatomy and balancing of the cruciate ligaments, the 4-bar cruciate linkage system. So the anterolateral portion is tight in flexions. That's why if the flexion is tight, in some time take a little bit of release the anterolateral part of this PCL. And posterior medial part, if the portion is tight in extension, this part you cannot touch. If you are releasing the posterior medial part of the PCL, then definitely you have to sacrifice the PCL. In that case, you will compromise the surgery and you have to go with the PS surgeries. So right now there is a, thinking when there is a, right now I'll show you the cases now, a few of the cases, because there is a, if you can say many of the things where I'm a CS surgeon, I tell you that this is there, but the PS surgeon says, no, this is not raw, this is not acceptable. If I say, so there is a controversy is there. Don't want to controversy, I'll show you a couple of cases, difficult cases where we feel that tyranny is difficult with the flat polys. In the gross varus deformities, flexion deformities, gross valgus varus, morbid obese patients, stiff knee, osteosynthesis with the TKR with implant in situ, TKR with the pre-prosthetic fractures and revision. These are the conditions where we can use the shear knees with flat poly. Now, first case, I'll show you the varus with fixation deformities. This is a 45 years male, and it's a morbid obese patients. It's a varus with fixation deformities. Right knee is the varus, 35-degree varus with fixation deformities 20 degree, and the left is the varus 30 degree with fixation deformities 20. And our hip bones, both the sides with the normal limit, and the spine also with normal limit. This is the pre-operative, I think, posture where you work. He hardly work because of this gross varus deformities. This is a scanogram. You can see the huge osteophytes here in the posterior part. We start operating the patients. Now, in the difficult cases, there is some controversy whether you're doing the unilateral or bilateral. Does navigation have any age? Inventory, I think even today also in such difficult cases, I always keep a PSO semi-constant type of implant in my kitty because you do not know anytime you can come across the complication. It's better to keep the inventory with you in all type of implants. The bone defect, definitely there are the medial bone defect is there. Then you have to be ready with this wedges, or you can, whatsoever you're comfortable, you can cover with the autologous bone graft, or you can lateralize the tibial component, but I'm not absolutely in favor of lateralize the bone component because in that case you are compromising the axis of this tibia. In that case, the life of the implant will be less. In that case, you are not supposed to do it. Basically, better to make the defects either with the wedge or autologous bone graft. Since I have a navigation, so I always prefer to do with the navigations. So I use the navigation for doing the surgeries in all type of surgeries. And here, because of the lot of defects is there, I cannot come. This is a lateral 13 mm and 5 mm. I want to get the less amount of cut. In that case, what I did, I proximalize this femur cut because this is the navigation cut because this is the maximum. I cannot reduce more than that because 13 mm lateral cut, I want to make it at least 11 mm. So I 2 mm proximal shift to the cut, less this is femur cut. This is the way I make the defect on that because I take all the cut of the femur and then I made the tibia. Then I fulfill the tibia defects with the bone, fix with the screws. Now, this is the final implant positioning after the, this is the X-rays, post-op X-rays. We have done the CR implant in the both sides with this 9 mm flat poly. This is absolutely, I think the balancing is absolutely perfect. And this is the screw, I made the tibia, middle side of the tibia and both the sides with the screws and autologous bone graft. The third post-op day, the complete correction of deformity. This is the post-op scanogram we have taken. This is full extensions and the flexion is more than 110 degree. Same day, I make the patient walking in the same day. 1 or 2 days, we put the brace, and from third day onward, one patient muscles was quite, quadriceps was good enough. Then we allowed the patient to walk without the brace. This is the valgus knee. Valgus bilateral approach, either maybe the Kebish approach or the conventional middle parameter approach. What's the approach is comfortable with you guys? Because I always feel that the lateral valgus knee is always best approach. The lateral approach to the Kebish approach, I always do that. Is very good. It is very easy, and because when you open the lateral approach, the defect is just in front of you. It is very difficult to manage the defect in the lateral defects. You can put the bone graft or screws or wedge, whatever you want. It is easier. But only issue is that we are not that much oriented, because mostly are opening the varus knees. We are not used to opening the valgus knee. That's why if you are not used to, then we have a some fear whether you can able to do it or not. I'm telling you, it is a very easy approach, and it is very easy to correct. If the valgus knee is there, we always should try the lateral approach. The fewer rotations, you can go to the either navigations, or if it's the standard manual, then you can the 5 degree. Same way I cut the distal femur cut first. And tibial defect is mostly contained defects, because this is a pre-op. This is my standard practice after anesthesia. I feel that whatever correctable defect is there, in that case, you can have the idea of the ligaments laxity. And see that the defect is contained defects. Mostly the all cases, it is a contained defect. But these contained defects, if it is more than 2 millimeter, if it is less than 2 mm, then you can come with this only the cement. If it is 2 to 10, then you can come with the screws. If it is more than 10, then you have to put a graft. It looks like it's around 2 to 4. Then you can easily come across with the cement. In that case, there is no need of putting a screws also. Then we are operated with this shear knees and with a flat poly. 9 mm flat poly. This is the immediate post-op. And see the degree of flexions. Patient is absolutely comfortable. Third post-op day, patient is working without support. In all cases, I don't use the tunic. That's why patient without post-op rehabilitation is very easy if you're not using the tunic. This is the valgus with varus deformities. This is the difficult things. Now the difficult things comes. This is a left side is a valgus, right side is a varus knee. The patient is osteoporotic. This patient was operated during the COVID time, because the patient was about to operate in the month of February or March, something like that, but not operated. But patient was scared because of the COVID, but she was on bedridden. She was certainly working. But she thought that after a couple of 1 or 2 months, things will be okay. But if it is not, then he came on the 2nd or 3rd June. 3rd June, she was with me. 3rd June 2020, she was with me. It is a very difficult one, because this is the posture and this is the defect. On the left side, this is the contained defect, is the valgus knee, and the right side is the varus. This is the scanogram. This is the CT scanogram. This is the X-ray scanogram. This is the defect. Right side is the this is the right knee. Right knee, the varus knee with the FFD, fixation deformity. Left knee is the valgus with the recurvatum. Right knee, the varus 25 degree varus with fixation deformity 20 degree. Left knee is the valgus 30 degree, recurvatum 20 degree. Now, this is a difficult case, but I'm operating such case with the shear knee. Always you have to keep everything with you, because you are not sure anytime you can come across the complications. I'm talking of the left knee here, because the right knee was the standard knee is what I'll show you in earlier cases. Same way I approach on the medial parapatellar approach, and I put screws, I made the defects, and I come across with this shear knees. This is a left knee. I approach with the Kebish approach, lateral approach. You see, when you open the approach, this is the defect is just in front of you, and this is the defects, and this is the contained defects. And because another problem is that this patient was having the recurvatum. That's why we put the tibial slope 0 degree. And we take the big minimum cut. You see the lateral condyles. Lateral condyles, the still cartilage is there. It means we haven't cut anything in the lateral sides. We take the minimum cut. Only the very, I take this cut with the navigations. And this is a very minimum cut in the medial sides, and there's no cut in the lateral sides. And the lateral side, there is absolutely no cut, because the defect is I just curated and I put a screws. This is a post-op X-rays. This is the right side. We put a defect. The middle defect is maintained with the bone and screws, and the lateral defects in the right side, left side, we put a screws and bone cement. This is how we done with the shear poly, shear knees with 9 flat poly, perfectly balanced soft tissues. Basically, the BCL, PCL helps to stabilize. See, there is no gap, and there is absolutely properly balanced knees. This is my standard practice. In the day one, I made the patient stand. In the couple of days, I put a splint in both sides. The patient was defect was too much. The second post-op day, patient was comfortable. Patient was working with support in the hospitals. This is 40 days. A good amount of quadriceps strength. She can hold with 1 kg cuff. This is a wet cuff in the right side. The left side also, because she was having more problem with the left side, because left side was a valgus knee with recurvatum, with a multiple deformities, with the bone loss, with the muscle wasting was there, but she was very cooperative. She had done a lot, good job. And after 40 days, see, the patient started walking without support. And I think this is the biggest gift I got in COVID time, because I operated with patients in COVID period. The month of June, the peak of the COVID, I was denying to operate, but patient was forcing me, because she was crying. She was telling it hardly make a difference if die of this COVID, because I want to leave. I cannot leave my life on the bed. Please operate me. I'll give you all the written consent, whatsoever you need. I'll give you the written. I forcing you to operate. And I think this is the biggest gift I got in COVID time. And see, after 40 days, our patient is absolutely comfortable. I'm in touch with the patients. Today only, I got this video. I asked the patient to send the video. See her smiling face. She is very happy. This is absolutely 2 months. 8th of June, I operated. And right now, today is around exactly 2 months. And she is smiling face. She is absolutely comfortable. And there is no lurch. And there is a very comfortable movements, and absolutely without brace, and patient is walking. So this is I think, very difficult case to operate. This is another case, same problem. This is the defects on the right side, is the valgus, and the left side is the varus deformity. 71 years female, mirror image deformity, osteoporosis, contained defects, and patella baha in both sides. Is something similar type of patients. Global laxity, scanogram, these are the difficult case. And you have to keep ready, because right side, you say there is a very much contained defect. And such cases operating, you have to keep everything with you. You have to keep all the semi-constant implant and all types of wages and available things. Even you can keep the things because anytime you can come across open the whole knees. In that case, you have to put a constant implant also. So you have to take some time, and it takes every cut is very important. No release. Basically, you have to take care of the any type of release and patient. And whether we should operate such case or not, that is also another issue. You have to explain to the patient attendant, because such patients need more time for the post-op rehabilitations. Because when patient, once you operate the patient, then suddenly patients start comparing here the next door patient, and he or she says, my next door patient is very comfortable in the 1 month of time, and I am not doing well after 2 or 3 months, 4 months also. Because such patients needs more time, because they're bed in for more than a year. And the defect is a little bit of correctable, gross quadriceps wasting, poor muscle mass. In that case, you have to see, if you want to see whether there is a quadriceps strengthening is there is a hardly a little bit of flickering. This is a protocol is there. This is my standard protocol. We get the spine X-rays and MRI, hip X-rays, scanogram, quadriceps muscle strain, DEXA scan, implant inventory. We keep everything with me before start the op surgeries. Same thing, right knee, we start with the Kebish approach, minimum bone cut, atrophic lateral condyles, no release. Absolutely, this type of knees doesn't need release, and remove osteophytes. And we are using the right side 5-degree offset to lateralize, to medialize the implant, tibial implant. 5-degree offset we used, and we rebuild with the bone and screws the right side, and the left side also we using the we build the middle defects with the bone and screws, and this we absolutely come across with the implant with 9 flat poly, because there's a little bit of opening on the middle side of the right knee. But in such cases, because ligaments are so relaxed, because we give the patients in these splint knee immobilizer at least for a month or 30 to 45 days. And usually the tissues and ligaments get contracted, and this goes off because the PCL is there. And in such a bad case, also PCL was very healthy, PCL was intact. In that case, this release, this space gradually it reduces, and sometimes after month, after 3-4 months, 6 months, you get the X-ray done, you see the knee is properly balanced. This is 20 days post-op follow-up because there is absolutely no strain, so we have taken the bar to make the patient stand. This is the 50 days follow-up. At home, patient start walking with this walker. This is the 50 days, is the quadriceps strength. She can hold the limb. See, there's a good quadriceps strengthening on the right side. Because right side was more defect, it was a valgus knee. There is a defect in the bone defect, valgus knee. There's the least amount of quadriceps strength was here. But she worked well. She did a good rehab exercises with weight, and it comes with this good amount of strength on the right side. She can holding it for the long time. The left side, she is able to hold it. It means a good quadriceps strength. This is the 9-month follow-up. She was having problem in the spine also. She is from a village. She is now declined to come for the checkup. She is happy because she is pain-free. She can walk with the stick. She is not eager to come and come for this. I called her multiple times if I want to get the X-ray. I want to see what she refused. She is because I'm very happy walking with the stick and I'm happy. No problem. Proper planning, skill, and patience can get into the primary implant in difficult cases also. PCL remains intact and healthy, even in the such bad cases where there is a bone defect, bone loss, so much of osteophyte, still the PCL is intact and PCL is healthy. And PCL helps in the ligament balancing. This is the morbid obese. This is another topic. Most of the surgeons feel that the morbid obese patient is very difficult and you are not supposed to perform the shear knees. But my experience, my opinion is that the obese patient is the best patient for doing the shear knees. Because see, when I've seen, this is my experience, when the obese patient, the knees are generally very, very small knees. They are either the little A, B, C, something like that. So what's the company who pick up the smaller amount of knees? And their size of the knees is very big because of the fat, because of the associated surrounding fats. It looks at the huge knees, but open and so much of osteophytes there. If you remove the osteophyte, then you come into the very small knee. The huge patient, small knee, and if you really want to do something with this PS, then hardly there is an issue with the saving the condyles, and sometimes it is difficult. So these are the cases I think fit for this shear knees. But only issue is that you have to be cautious. You have to see, because many of the patients there is a recurvatum. In that case, you have to reduce the tibial slope. You have to think twice for the release. You should never release the tibia fast. You should start with the femur first. You don't release the tibia, because if you need, then only go for the tibia release. Otherwise, not. You don't. In such patients, basically they don't need any release. Only the minimum cut, bone cut, you can accommodate the shear implant. This patient is 121 kg weight, 68 years female, bedridden for more than a year, multiple comorbidities, osteoporosis there. Another issue is that operating such cases, whether you should operate both knees together or single knee, because sometimes in general these patients takes a little bit of more time, but if you're experienced, then you can reduce the time also. The navigation gives best result. I think this is my experience in all these patients. Definitely I'll choose to operate with the navigations. This is the soft tissue already discussed. Soft tissues are relaxed, cut less in the femur. Don't medial release before cuts. Tibia, less slope. Mostly these patients have a recurvatum, the less slope and short tibia stem. And distal femur cut also you have to reduce, because if there's a recurvatum, you have to reduce the distal femur cut at least 2 to 4 mm. This patient is done under navigations because in such cases when the weight is more than 100, then we put a tibia stem just to, with the soft bone, we counter the, because there's a chance of sinking of the tibia, and this for the weight bearing surface of the tibia, we put a stem, cemented stem. This is the immediate post-op patients. This is after around 2 months time, patient started walking without support. This is a another patient. This is my practice before a day before surgeries. I want to take the videos in all my patients. This patient is 62 years, female, 104 kg weight. This is a 55 years patient, 94 kg weight. This is the obese patient. She has been working with this worker for more than a year of time. This is a pre-op X-rays. This is the post-op X-rays. I put a stain done with the CRNEs. This is the pre-op. This is post-op done with a 9 mm poly and with stain. The day of surgery, all my patients are standard practice. I make them stand. This is the day of surgery. Both the patient I made them stand, operate the same day. The third post-op day, patient is walking without support. There no brace used. So even in the, I think these are overweight patients. I think my tips is there not to use the tourniquet, less femur cut, reduce the tibial slope, use navigation if it is possible, and you don't invert the patella, because if you want to invert the patella, it takes more cut. You can subluxate the patella, you can get into the surgeries, no problem. And if you follow the tips, I think these patients, the obese patients, the CRN is possible, and the result is amazing result. They are the must praise, smart gratitude patients than the lean thin patients. I think they are much more complaint the lean thin patient, but with the fatty patient they have a less complaint. They are very happy patients. You can say they're very happy patients compared to the thin patients. The stiff knee. This patient is having stiff knee. Hardly any movement. See, this is the anesthesia. Patient is holding. Absolutely stiff. This is absolutely stiff. Now the tips are the patella release from the femur. Most issue is the patella, because when you open the knees with the parapatellar approach. Now the release from the femur is an issue, because mostly the patella is adhered to this femoral condyles. When you have to care for the release the patella, and you have to release the quadriceps tendon. Q release, quadriceps release is very important. You can take a flat osteotome and you can release the quadriceps subperiosteally. It will give it a little bit. Then remove all osteophytes. I think then subluxate the patella and prepare, because in such case only if you can subluxate the patella, that will solve the problem. Because sometimes subluxate the patella is difficult. You have to care for this the quadriceps tendon. You have to release the patellar tendon also, and you have to release the patella also, because you are not supposed to get any complication with the patella. And all cards are as recommended. We start with the femur first. When the femur and everything is very easy. But because it has been seen that if you release the quadriceps properly, only the tips is there, subperiosteal release of the quadriceps with the straight osteotome, it gives solve the purpose.
3, 4, 5, 6, 7, 8, 9, 10. पैर नीचे करो.
See,
नीचे करो.
around 90-degree flexion is already there.
मोड़ो. हाँ.
And patients can climb stairs.
पैर उठाइए.
Even after surgery.
1, 2, 3, 4, 5, 6, 7, 8, 9.
Patients are climbing stairs. This is another important factor, the TK with osteosynthesis. I think very few I've gone through the literatures way I did. I think this is I'll show you the tricks of operating osteosynthesis with TK. That is possible only with the CRNEs with navigations. This is a 54 years male, osteoarthritis both knees. BMI is 38. It means obese patients. Right knee 15-degree varus, 20-degree fixation deformities. Left knee 20-degree varus. It means a bilateral varus deformities with the 20-degree fixation deformities, and there is a fracture in the middle condyle on the left side. Confined to bed for more than 4 months. No history of trauma and fall. It means, see, this is the April 19. This is the right side. This is the defects. There you can find out this fracture line. This is the stress fracture on the left side. This is on the April 19. This is the July 19. This is the stress fracture is increasing. And this is the time when patient approached me, appeared me the August 19. August 19, this is the stress fractures. We've done the CT scan. This is the whole medial condyle, intracondylar fractures with the osteoarthritic changes. Now the issue is that what to do? Now that there is a there is a, I think, difference of opinion. People say that I'll first fix the middle condyle first, then I'll go ahead with this TKA because this patient is already bedridden for the 6 months. That is a stress fracture. And when there's a stress fracture, and if you again fix the bone and you just let him lie down on the bed and you want that this fracture to be healed up, it will take another at least 3 to 4 months of time. It means in that case, the things will be more complicated because the patient is already having osteoarthritis in the other knees also. So only issue is that you can reduce the morbidity only you can perform both the surgeries together. You can perform both the surgeries together. If you can perform the TKA with fracture fixations and the TKA, that will solve the purpose. So we plan the way like this. We plan the everything is in a one go. It is a difficult case and difficult because I'm trained to do it. I plan, but if you are not trained, then you are not supposed to. It's a huge work. Then you should better divide the work in 1 or 2 sittings. You can operate the right knee first, then you go for this left knees. Because I've been operating then I've been used to operate such things. Then that's why I opted the whole surgeries in one go. So I start with this. See, the fracture is not united. This fracture is not united. This is the fracture on the left side. This fracture is not united. It is moving. It's absolutely non-union. We fix the fracture with the plate and screws, and we can get the anatomical fixations of the fracture part, and you put a graft. Because already done the right knee first, then you have a good amount of bone with us. You put a little bit of bone in that because it has got anatomical fixation, so hardly we need any bone graft over there. Because if at all we need a lot of bone grafts, we have. Now the challenge is the distal femur cut, then rotations, and then the alignment. We use the navigations. I think there is the only way you can do it is the computer navigations because plate is already there for the distal cut and the amount of cut and the alignment. I think best way you can do it is this computer navigation. You can give the perfect alignment of the whole knee replacement systems with this computer navigations. We have done the computer navigations after fixing the plate because this fracture was first fixed with this plate. Another thing is that this is the left side because this is the LCP, but I use the right side LCP in the left side because with the medial side we use this bone in the medial side because we don't have any plate. Either you have to go for this less profile, this fracture was intra-articular and is a huge fracture is there. So we have the options. We can use a filo. Sometimes many of my cases I'll show you in another case where I use the filos in both the sides. But see, is the medial condyle fractures, and I need a stout, a heavy duty plate on the middle side of the LCP because what LCP we have, only the LCP we can put the lateral side. So I have chosen the plate from the right side LCP. We use the left side, and this is the LCP I used for the fixation of the bones. One bones is fixed, then I took the navigations and I take the distal femur cut. I operate the bone. This is the immediate post-op X-rays. And see, because I feel that this fracture was well fixed. I was planned to put a plate also over here on the left side, but it was fixed well on the middle side. This is buttressing the fracture sides. So that's why I put 2 screws only, and it was suffice to get a good anatomical fixations of the fracture. And then I use this, in that case also, this PCL was intact. I'm telling you, and this is the type of knees I use this here, the pivot knee. Because in the pivot knee, you need to cut because if at all the PCL is not intact and you have to sacrifice the PCL in that case, you need to take the PCL remove the PCL or there is no box cut in the pivot knees. So in these cases, this is the pivot knees. I use the pivot knee because in the pivot knee, if at all PCL was not intact, I can exchange the poly and I can come across the shear knees, primary shear knees with the primary implant, primary shear poly. But this poly will be the ultra convex. But fortunately, this is the left knee. The PCL was intact, PCL was healthy. After fixing the bones, everything was fine. I took I take help the navigations. I take all the cuts of the femur. Then I came to this tibia. Since patient was heavy and bones was not porotic bone, I opted the stem. I put stem on the both the sides. This is in the left side. Right side was the pretty straightforward because this was a varus knee. I compensate the defects on the middle defects with the bone and screws. I made the defects. Then I put a standard anatomical implant with a 9 mm flat poly. This is a 30 post-op day. Patient was absolutely comfortable. See, why I opted this? Because if I opted this surgeries, then only I can make the patient immediately after partial weight bearing after 3-4 days, and after started immediate the post-op exercises, weight bearing after 3 to 4 days, partial weight bearing on the left side, full weight bearing from the right side, and gradually I increased the weight on the left side. And after 30 days, he was allowed to walk without support. This is a 3 months follow-up. It was all the fracture was absolutely intact, and there was a no reductions, and it was uniting fractures, and everything, all implant is intact, and patient was doing very well, absolutely painless, and the plate was also in situ. This is a 90 days follow-up. Patient was comfortable with a good range of movements, with more than 110-degree flexions, full extension. There is no extension lag, and patient was allowed to do the stair climbing also. He was doing the stair climbing. This is a 9 months follow-up. I asked the patient to send the X-rays, and here sees the complete union of the fracture and the implant in situ, and everything has gone well, and patient is absolutely comfortable. So simultaneous primary TK with histosynthesis is a very viable option because I think it reduces the morbidity. It gives the more confidence to the patients for the TK, because total knee arthroplasty, I think is one of the best surgeries right now available we can give to the patients. When the patient is lying on the bed for the last 6 months, and after surgeries, if patient is allowed to walk the next day, then it gives the confidence to the patient, and it gives a very good I think is a very good feedback for this the procedures, because the knee replacement needs because this is the procedure. Huge number of patients are waiting in India, but mostly many of them are scared. They feel that this outcome of the surgery is not good. So these give the positive feedback for this arthroplasty procedures, and I think we should opt for these procedures. And this is possible, everything is possible, but you have to go, because once I try to find it out in the literatures, there was not much mention of this primary osteosynthesis with the TKA, because in many of the cases they use the tibia femur stem, because this is possible only you were using the navigation, because while you fix the plate, then you cannot put a rod inside the femur to take the orientations, to take the distal femur cord. In that case, you have to use the navigation in any form, either in the standard navigations, or you can right now so many type of navigation is available. But you can some manual. I think I'm not very much master in that, doing this the primary or without machines navigation. But some people try that. But I think you can handheld navigation or some. I think some mobile navigation. Whatsoever type of navigation you need to for this only the femur cord, distal femur cord. That is the most important part. And you have to choose for the implant where you can come across with the shear implant, because when you put in the distal femur screws, you cannot get into this standard PS implant. So you have to opt for an implant where if your PCL is not intact, if you're not very much comfortable with the PCL, in that case you can get away or get with this some craft poly or some different type of poly which can help you to get rid of these issues. So operating such fracture with the TK, you have to have a navigation in any form, and you have to have a implants which either you can put a standard flat poly or a ultra congruent poly or UC poly, whatever poly is important, because you cannot take the box cut, because if you do the box cut, the screws are there, you cannot perform in both the surgeries together. And the thing that you have to reduce the fracture in anatomical, because if you are not able to reduce the fracture in anatomical corrections, then there may be difficulties in weight shifting. Then maybe the problem in the bone union also. So it is better to get the anatomical reductions, and when you open the knees, everything is in front of you. It is not very difficult to get anatomical directions, and you can easily get into this. Only issue is that choosing the implant is difficult. But in such cases, I think the Philos proximal humerus plate is sometimes I use. I think that is a better way of doing it in the middle side. But it is a low profile plate, and you cannot use the bigger one. In the middle side, basically, you need a low profile plate only. But since this is a huge patient, 38, BMI was 38, the obese patients, and with a huge fracture extending to the cortex. Though I feel that I use a good amount of plate LCP. That's why I opted for this LCP, and we fixed it with this proper screws. Then primary implant should be considered. That is the beauty of this TK. I think always you should compromise with the primary surgery with the least constrained implant, because while you use the least constrained implant, you do not know a patient might need another surgery in near future for any reasons. In that case, you have a left. So always I feel that you always start with the basic minimum implant. Starts with this you can unicondylar, then you can come because the CR knees, then you can go for the PSA, something like that. But doing where the limited indication is they are doing the unicondylar knees, but this is also beautiful knees. But I think if you can come across, you can solve the problem with the unicondylar. Always you should start with the unicondylar first, then you can go the CR knees, then you go the PS, something like that. You should not jump into the constraint in one go if it is could be solved with the other type of knees. And you can take the opinion from your seniors, your friends. You can take the. I think it is always better to take the opinion. We should give the best treatment, available treatment for the patients. And you cannot come to the conclusion before consulting your friends that this is not possible. Everything is possible. You can take the opinion to find out to whom to talk, where to take the opinions. Now, this is another issue, the TK with implant in situ. This is under 66 years male, delayed union with implant in situ, posterior arthritis with 30-degree varus deformities. This patient was operated for the distal condylar fractures, femur, operated 9 months back in some of the hospitals. And patient, this bone is a delayed union, is uniting fracture, and is a painful. Patient was gross varus deformity, painful, 66 years, he hardly works, and you want to get rid of this problem. Now, issue is that he has been visited a couple of doctors. All says you have to wait till the fracture unites, and he's fed up. Nobody give you the assurance when this fracture will unite. So I decided I will operate this case under navigations, and I won't remove the implant. I will remain the implant there, and I'll go for this total knee arthroplasty. But when there is a implant there, then you have to first exclude whether the patient is having any infections or not. Because when there is an implant, there is a chance there is maybe some underlying infections. So you have to examine the knees locally, and you have to take all the blood investigations like CBC, ESR, CRP. Normally, non-TK, we don't advise ESR, CRP, but in such cases, always you should think for the ESR, CRP, because you have to exclude infections, because patient is already implant is there, moreover, over and above, you want to go for the total knee arthroplasty. So first you have to exclude infections. If there is a not infection is there, then you can plan for such surgeries. And here is also the navigation is must, because you cannot plan such surgeries without navigations. And the minimum removal of the implant, if it is come on the way, then only remove, otherwise not. No, ways like this, we started with this humor prepared first, this minimum bone cut, because it is not difficult one, because only issue is that if you have a navigation, everything is very easy. If it is not there, because bone is fracture is not even you're supposed to expose the fracture also. You can, because it is a uniting fracture. Only issue is that it is a malunited fracture, and you can say this is you can correct this deformity with the intra-articular deformity, intra-articularly with the bone cuts. So everything is possible with the one go, with one solution with this TKA, because even if the bone unites, because this fracture was uniting with the malunion, whereas malunion is there. So you can correct the deformities, you can get into the problem of the delayed union, you can give the one-shot solution, you can make the patient walking in the next day without support. And of course, it shows the minimum bone cut. Same things I did. I operated with this minimum bone cut. Then we use the navigations. I just removed only one screws which was coming into on the way, and we put in the primary CR implant. Here also I use the pivot piece. In such cases, I pivot knees give the very good result, because if you are not sure of this PCL, because patient was operated previously, whether maybe the PCL is damaged, maybe some, because I have seen also if the patient is operated a couple of times, maybe also, but PCL is always intact. PCL is very stout. I think most strongest ligament available in our human being is the PCL. We have to should respect the PCL. It is even in the very bad knees also, even operated knees also, PCL is always there. And how we can able to balance ligament perfectly. See, this is I make the patient walking in the same day with the brace, and he was getting the good. This is in top only the second day. This patient also I operated in the COVID time, because patient was very frustrated. He was on the bed. So this patient I operated, I think, 27 July, only back in the month, 27 July. Because this patient was also frustrated. All I operated during the COVID period are frustrated patients, because not able to work on bed lying. He is having some heart problem also. He was very frustrated. He do not know when the things should be going right. He says, yes, operate me. I'm not doing well. And I think best way you can solve my problems. So I did see the patients start working in the hospital only, start working without support, and we can good alignment is there, and the good corticeps strain, and patient is doing very well. The proper implant choice and meticulous planning can reduce the morbidity. See, this is the only way you can reduce the morbidity of the patient. An excellent outcome. Patient is very happy. Increase confidence of the procedure. That is very, very important. I think all the joint replacement surgeons, I just request them, you do the very good job. Huge number of patients are waiting in India who needs such surgeries. But only issue is that we have to perform them. We have to give them the very good result. And if the result is good, then it gives a very good confidence to the procedure. They say that this procedure is good, you should go ahead with the surgery. If the things are not doing well, then they say, no, they're very bad procedure, should not offer this total knee replacement. And here also no constraint implant used in any, no constraint component used, no poly, nothing. It is absolutely simple primary knees. These are another issues. Another patient was this plate is there. I can really come across is the TK without removing the plate. Is a CR knees with a 9 mm flat poly. Of course, such operating such cases, you need a navigations also. This patient was operated multiple times, bedridden, 110 kg weight patients. The patient was operated for the femur. This is not uniting fractures. This is also not uniting. Patient was operated somewhere else. He came in the bed and she wants to walk. So what I opt that I planned for surgeries. I did the TK with the implant in situ, and patient is did very well. The periprosthetic fractures, this should have tell. This is a 91 years old. This patient is around 80 years old. This patient is 80 years old. This is a periprosthetic fractures, but patient was operated with the CR knees. So it is better I can put a dual plates. I think the best way of you can do with that dual plate, that is a very good fixations. And if the CR knees is there, you can, if the chance is there, you can put a good amount of screws. You can, that is a better fixation of the plate. And see, it is a uniting well. This is a 3 months follow up. This one is united and allowed the patient for the walking. The revision knee, I'm telling you, even in the revision also, CR knee revision is very easy because a good amount of bone. Even using the revision implant, you can use this 9 mm poly, the 10, 11 mm poly, minimum amount of poly. You don't need any sleeve, you don't need any cone, because I have seen if you're using converting the PS implant, PS knees into this revision is very difficult, because if you remove the small knees, if you remove the implant, the hardly few amount of condyles left, and there's a doubt whether the LCL or MCL is intact or not. In such cases, you might have to go for this some constrained implant or fully constrained implant. But in the CR knee, the whole amount of bone is left. So at least you get the good amount of this MCL and LCL, and there is hardly any chance of disruption of these implants, and you can get into this primary semi-constrained implant. It means that the patient result will be very good. Thank you very much. This is my honest, I've shown you a couple of cases where we can show you I think all cases we can do with the CR knees, and I think we should try with the CR. Because, when I started with the CR knees, people say, no, there is a limitations only. What is the purpose why I'm here to share my cases? Today I came to know, I realized that all cases you can do with the CR implant, But only issue is that you have to think, you have to plan the surgery, you have to plan the implant, and you have to patience with you, because saving the PCL is an art. It is not a 20 minutes, 30 minute surgery. If you're a busy surgeon, if you feel that I want to finish my surgery in 30 minutes, in that case, it will be very difficult to save the PCL. But saving the PCL in hours is a time-taking surgeries. But definitely, if you can save the PCL, result is amazing. Result is very good. It is for the patients. Balance is good. Patient recovery is good. And thank you very much. I hope that if you have any queries, I think the delegates, any of us, every time operating, if you can come and show how you're operating, you can join me and I can show you why you operate. Thank you very much. Hello? Yeah.
Thank you. Yeah. Thank you, Dr. Sujoy. That was an excellent. I think basically I have not seen so many number of cases of CR knees together in one presentation. All variety you have. I think you have covered from the basics to the most complex to at the end. So I have few queries for you. So you are. Have you completely given up the PS knee?
Yes.
Okay. And with the CR knee, see, it's like that. I was going to ask you that the Indians usually come late with so much, but you showed such great deformities using the CR knee that I cannot ask that question anymore. You are already managing it very well. So you don't release the PCL at all. How do you actually save the PCL in such complex, unstable cases?
No. I'm saying, start with the only issue is that CR knee, first we balance with the flexion, then you come with the extensions. We don't release any tissues. First, femur first. We cut all the, then you see. If you need accordingly, you release. We never release. Even I'm telling you, even the gross varus deformity, if you feel that your MCL is a little bit off, relax. In that case also, if PCL is intact, you can come across with the CR implant. But if you are doing a PS knee, and if you feel that your MCL is not intact, definitely you have to go for the semi-constant implant. PCL, I think that is the best structures in the knees. We can balance your knees. We can rely. If I think some issue is with the ligaments, with the medial or lateral collateral ligaments. But I think both the pillars are intact. Even the little bit of PCL is, then you can come into the ultra-conjugate poly or UC poly. But I am not using too much of ultra-conjugate poly. I feel that is a type of semi-constraint. I don't want to use any type of constraint implant inside my knees. Absolutely primary. I fond of being on a flat poly.
So it's wonderful to see such a wide array of cases. So I wanted to ask you a question about that stiff knee young female which you showed. What was the cause of her stiffness? Why was she so stiff to begin with?
Many of these Indian females, I think there's a trauma. I think she had a history of trauma and she was put on a plaster long back. Once in the plaster, she was not rehabilitated properly. And she made a habit. She started walking with only the stiff knee because she felt that reduced the pain. With a post-trauma.
Post-traumatic. Yeah. So it's mostly post-traumatic because in Indians, we usually don't see stiff knees so commonly, at least in the older population.
Yeah, it's not that common. It's absolutely stiff knee. This was absolutely stiff.
Yeah, she was absolutely stiff with no movement at all. Even under anesthesia, there was hardly jog of movements.
Yes.
So that was one of the most tough cases, I think, for you. How much quadriceps to release? That is where you required releases.
No, I don't need to release. Only issue is that you have to, first things you have to care for this, release the patella from the femur. Then you have to release the quadriceps tendon from the subperiosteal release of the quadriceps tendon. And you just subluxate the patella and you release the quadriceps, osteophytes. If you release the osteophytes from the femur, then and you just prepare the patella, you will get a space, you can lateralize the tibia. Patella, and once the femur is exposed, when you cut all cuts the femur, that is very easy. But if you want to do with the tibia first, in such cases it is difficult. You study the femur first, then things are very easy. I feel that it is very easy because I'm a serious surgeon. I think because I always start with the femur first, because I think once I cut I accept the tibia is the most important cut in the tibia and the TKR. Once you cut the tibia, nothing left. I can do something wrong with the femur. God will mercy for that doing something wrong with the femur. But he will not save me if I'm doing something wrong with the tibia. Tibia, I think, is most important. Tibia cuts, I think, most important cut. After all cuts, you take the tibia because of all release, you can find out how much amount of cut you can do. In the varus knee also, I cut very less because if you remove the osteophytes, After cutting the femur, there is a chance you can remove the osteophytes. Then you know how much you have to cut. But sometimes do not cut also. Because so much relaxed, you do not cut. You just go for this, the condyle, little bit of just so cheap. I show you the case, valgus varus knee, valgus knee. I even didn't cut anything on the, I just make multiple holes in the lateral condyles. Because the atrophic condyles, even the tibia also, I put a stem, that's all, I hardly cut anything. Because if you cut too much, then you cannot accommodate with this here. Then you have to go for this other type of knees. And it is a 20-minute surgery, it's a patience.
So now I come to approaches. So when do you decide that you should do medial parapatellar approach, and when do you decide that you should go laterally?
See, I'm all valgus knee. I feel that I always go for the lateral approach. That is a very good approach. Only issue is that we are used to of doing the varus. We don't want to change it. Basically, it is a mental block. We feel that I can do it. Of course, we can do it. Any type of valgus knee. I presented many of my cases in the conference. I told that many of the senior surgeons, no, I am very much comfortable with doing the valgus knee in the middle parapatellar. I say everybody can do it. But thing is that in that case, you have to struggle. If you lateral parapatellar approach, defect is just in front of you. It is very easy to get into the defects when you go the heavy approach, lateral approach.
And what about this stem use? I saw a lot of cases in the beginning of the presentation. Later on, of course, you have to use the stem because those are complex. Sorry, where you're using tibial stems. So how do you decide in this case I should use a tibia stem, and in this case I should not use a tibia stem?
See, I'm telling you, when the osteoporotic patients and the overweight patients, I always prefer to put a stem. I use a short stem, 75, fully cemented, 75 mm stem, when the patient is porotic and is morbidly obese patients.
Okay, got it. And all of your patients walk on day one?
Yeah, I don't use tourniquet. I never use tourniquet. I don't invert the patella also. I just subluxate the patella. Many of the times I use your subbustus approach also. And many of the times I use your trivector approach. And hardly I touch the quadriceps tendon. And I make the patient stand, if not walk in the day one. And the second day, third day, I make the patient walk. Cool.
And do you, what I was going to ask, sorry, I forgot. Do you, when you are using those stems, do you do the CR knees without the stems also, a routine non-complex varus?
Yeah, of course. Only the specific indication of the deformity is there, but I think the defect is there, the tibia defect. I have to compromise the defect with the bone graft or bone graft and screws. In that case, definitely, if the defect is contained defect, then I better to put a stem over there. Otherwise, that can sack.
So in the CR knee, the importance in the CR knee, the importance of this is that you can put a stem even in a primary implant.
Yes,
versus the PA, versus the PS knee, where most of the companies don't offer a stem in a primary implant.
No, you can use the primary implant also. Even in the PS also, you can use it, no problem. I think the implant, CR implant, the tibia is same. In the whether you're using the CR implant or the only difference is the femur and poly. Tibia tray is same in both the cases. Okay. Whether you're using the PS or CR, tibia is same. Only difference is the femur and poly. I think the most important part is the femoral condyles. I think forget about the PCL because there is a fight in the PS surgeons, CR surgeons, all the proprioceptions, all this rollback and this and that. But only issue is the revision. While you're doing the revising, the patient with the PS is size B, small size, hardly anything left.
Revision is a big issue. Yes, you're right. So the main advantage I felt is that basically when you're doing is that you don't have to revise. The revision becomes much easier with the CR knees.
Absolutely. You don't use slit, you don't use cone. It means you are reducing the cost of the revision surgeries. Because when you're doing the surgeries, even whatsoever, even in the best centers in the world also, there is a chance of revision, chance of infection or whatsoever is there. While you're doing the primary implant, primary knee, always you have to keep in mind, either you or any of your friends, any of your colleagues will be doing the revision of these patients. If you feel like that, then you will be the minimum implant. And of course, you will not go for this any type of constraint implant. You will keep everything. 9 mm poly means you are using the least amount of bone cut. So everything left for the future use.
What about the longevity of CR versus PS? Is there any research or is there your personal experience? How does it?
The research is the CR knee is, say there is a fight. Better not to ask such questions. Because every conference there is a fight of the PS and CR surgeons. I think right now CR is better, even in the India also, younger surgeons I think the shear knee people are opting, because previously there was only a flat poly. Right now we have a ultra congruent poly or double height poly, something like that, where if you have a doubt of the PCL, then you can do it. See, when I started doing shear, I was told that there is certain indication only you can do shear, but in certain the deformity or primary complex, you cannot go for this shear. You have to opt for the PS. But in that case, rheumatoid patients, I'll show you. I'm using all rheumatoid patients the shear knees. But previously, 6 years back, I was scared to put a shear knee because I thought that if there's something wrong, then I may be sued for putting a shear knee in the rheumatoid patients. But right now, I am very confident that even in the rheumatoid patients also, PS, if you properly decompress the PCL, is in all such cases, PCL is always intact, PCL is always healthy, and you can salvage the PCL. You can, in the rheumatoid patient also, you can do with the shear knees.
Okay, that's all from my side. I thank you very much, Dr. Sujoy Bhattacharjee, to show us a wide variety of cases. And for me, who's never done a CR knee, basically I may attempt a CR knee in my next surgery. So
Perfect.
it is, so it's a very wonderful implant according to what you have shown, and you can use it in all complex type of cases.
Yes.
So that is the magic which you have shown. I think you are a very skilled surgeon.
Thank
The
you.
way you have handled all these complex cases is a very big thing. And let's hope that we have you very soon again in a panel discussion where we'll have a CR versus PS
I'll be
discussion.
very happy. Thank you very much. I felt that.
Okay. Thank you very much, and bye-bye. We thank Dr. Sujoy Bhattacharjee, and we thank BioRed Medicines, the makers of Genius CR knee, for bringing us this webinar. Thank you, and bye-bye.
I'm telling you, BioRed is also having a Genius CR knees. I've used one
Yes.
cases. There is an excellent knees.